This is our second session of our AAP California Chapter 2 Telehealth project, sponsored by the American Academy of Pediatrics. And we have a great program today on we're calling it Telehealth 102, which is basically going to be pre-visit court considerations, coding, and billing. And we have a special guest today, Mary Jean Sage, who is the president of the Sage Associates. I'm going to move on to the next slide. So this session today is the second of a series of 6. I encourage you to look at your calendar invitation, because when I sent the calendar invitation initially, all 6 sessions were part of it. The next one is going to be February 18th on telehealth platforms. Then March 4th on preventive care via telehealth. March 18th, social and cultural considerations. And then April 1st, and don't be fooled, is going to be telehealth after COVID-19. So that's the lineup coming up. Also, as a reminder, on the right side of the screen, you see the structure of our meetings. So our meetings are going to be 1 hour long, the first few minutes of introductions. And what I do is I bypass introductions among participants just so that we can expedite the process of our presentation. I do ask everyone to put your names in the chat box. During the second portion, which is the case presentation, and we have today Dr. Tim Watson presenting a case. During that time, when you speak, you're very welcome to introduce yourself, because we want to know who you are and what organization you represent. But we'll do the individual introductions towards the end of towards the second half of our program. So today we have Mary Jean Sage, who is a nationally recognized speaker, consultant, and educator of healthcare issues. She's the founder and president of the Sage Associates. She has over 30 years experience in the healthcare field in both clinical and administrative arenas. She's recognized for expertise in coding, billing, healthcare compliance, and health plan audit response. Her strengths: managing cost, meeting regulatory compliance criteria, managing patient relationships, and maintaining a positive bottom line. So welcome, Mary Jean Sage. I'm going to stop sharing my screen so that you can see Mary Jean and she can share her own. Thank you, Mary Jean.
Okay. So thank you for asking me to be with you today. Telehealth has certainly gained in popularity due to the pandemic, which is a good thing, actually, that we're able to do telehealth now. So we're going to talk about some coding issues today. Therefore, we're going to use CPT codes. And I need to remind you that the CPT is developed and copyrighted by the AMA. It is probably more important than ever that you get a new CPT book for 2021, because we have had some major changes in the evaluation and management of services for your office visits. So important to get a new one of those books each year. So let me see if we can.
Let me know when you want the next slide.
Okay, so let's go on to the next slide and go ahead and get started. So to be successful with telehealth, there are certainly some things that you need to do before the visit, both with the patient and in your offices as well. So we're finding that for us to be able to efficiently do telehealth, we want to make sure ahead of time that we've confirmed the time and place with the patient, and so that they're aware if it's going to be audio video or audio only. If it's going to be audio video, you want them to be able to test their system. Typically, we will send some instructions out to them about if they need to download anything for, depending upon the platform that you're needing. You want to make sure that on their end that they check their camera and their whatever device that they're using to make sure that you can all hear each other as well. Always suggesting that they set their device, the camera, at eye level to make it easy for you to see not only the patient but the parent who is probably going to be with them at this point. If they're using some kind of a mobile that they have a fairly nice, quiet space so that you can all communicate well. Going on to the next slide, for you in the practice, you want to make sure that you have efficiently designed everything so that when you're ready to do the visit, we can make the most of your time. So if you're using, depending upon the platform, if you're using a secure platform, you will want to have a HIPAA business associate agreement in place with whoever your platform vendor is. That allows you to certainly safeguard protected health information and meet all the requirements of HIPAA. Also, we always suggest that your office staff get the patient signed on and ready to go so that when you're ready, as a clinician, your time is going to be efficient. So if we go on to the next couple of slides, Tomas, one of the challenges, and we can advance and go on to the next slide as well. One of the challenges you're going to have is right now there's not a lot of payer consistency with telehealth. Everybody has their own rules. Everybody decides what codes can be covered by telehealth, what can't. Everyone decides how they want you to report the place of service and whether you're going to use modifiers or not. But we're going to talk a little bit about that before we finish today. So the payer policies are changing frequently. Some of them have payer policies that are in effect now during the pandemic. We all are wondering what will happen once going forward, once the pandemic ends, and it looks like HHS is suggesting at this point that that public health emergency lasts through the entire year 2021, but after that, going forward, what happens. With our commercial plans, we have a little more latitude because in a lot of our states, we do have state legislation that requires our commercial plans cover telehealth. Any service that could be done in your practice needs to be covered as a telehealth service. We here in California have one of those as well. There is some confusion between what qualifies as telehealth. Is it office visits? We do have some online digital E&M services in the CPT book. Is that telehealth? What about telephone only visits? We have CPT codes for telephone visits. Many of our payers are not looking at audio only being telehealth. Again, there are some differences between the public health emergency because we've relaxed a lot of those regulations. So it's a real mixed bag of issues right now. And then lastly, you do want to all make sure that you check with your malpractice carriers and see if they have any specifics as far as telemedicine, what they want you to document, and what their informed consent requirements are. Next slide, I'm giving you a little
Mary
example.
Jean,
Yes,
one thing, your voice seems to come and go sometimes.
okay,
Just make sure you don't have, I don't know where your microphone is. If it
yes,
is on the laptop, make sure you're not putting papers on top of it or something.
okay. I
Because for
will
some
make
reason,
sure,
your voice
actually,
is, the volume is really strong sometimes and then it fades away.
it fades away. All right, I won't move around quite so much. That will help for one thing. So on this slide, I'm giving you an example of a tool that a lot of practices use where they've developed this grid, if you will, for the different commercial payers, as well as some of our government payers, where we get more information, what the specifics are as far as are they paying for telehealth, how do I bill it with a place of service, do I require a modifier or not, is there any cost sharing on the part of the patient. The issue with using a grid like this, and I think it is a good idea to do it, is the information is only as good as the date that you get the information because there are so many changes going on. So in my examples here, you can see I have an effective date of March and April of them here. You will probably want to check at least um, no less than quarterly, and I would say monthly, we see things changing. Now, we do all receive in our offices notices from the health plan as they are making some of these changes. So you want to make sure you have a staff member that's paying attention to those changes so that you're not only providing the services, but you're able to bill it correctly the first time around, not incurring any extra expenses as far as going as far as having to resubmit bills. So a good idea is fairly easy to develop. Just make sure that, and the important thing is that over on the right-hand side, you'll see where we can get more information. Those are the email addresses or the websites that will be important for you. So let's go ahead and talk, moving on to the next slide, about your visits and some of the changes for this year. We know that we don't necessarily have new CPT codes, but we do have new documentation and selection guidelines for our new and established patients beginning January 1 of 2021. And these are the services that you will be doing telehealth-wise. On to the next slide, Tomas. Thank you. So not the codes themselves have not changed. We have the same CPT codes that we've always had. And we're talking about office visits for new and established patients using CPT codes 99202 through 99215. Now, what's different this year is you may select your level of service based on either medical decision making, not necessarily history and exam and medical decision making, but just medical decision making, or you can select your level of service based upon the time that you spent on the encounter. We've done time before, but previously, if you were going to select your level of service based on the typical time for a service, you had to spend more than 50% on counseling and coordination of care. That's no longer appropriate for selecting time. So we'll go into the specifics a little if we can move on to the next slide. Let's just briefly talk about history and exam and what part does it play. So you still have to do a history. We still expect an appropriate exam to be done. They just are no longer a key component for selecting that level of service for that new or established patient. So it should be done. It should be medically appropriate. It should make sense with your documentation, and you, the clinician, will determine at what level you do the history and the exam. Do remember that a few years ago, we changed the documentation guideline, and your care team is now allowed to collect information entered into the health record as long as you, the clinician, do document that you reviewed and you either agree with the information or you make some appropriate changes. However, with our new documentation guidelines or the new guidelines for selecting your service, the time that the care team takes to collect that information does not count towards determining the time for the visit themselves. If we're going to pick your level of service based upon time, it has to be clinician time only. So let's delve into medical decision making, moving on to the next slide. Medical decision making, which is one of your options, it requires that you do 2 out of the 3 elements of medical decision making. Our elements of medical decision making are the same as they always have been. The number and complexity of the problems that you address, the amount and or complexity of the data to be reviewed and analyzed, and the risk of complications and or morbidity or mortality of patient management. There is a new medical decision-making table. It's on our next slide. It's a little hard to read. It's very similar to the old CMS risk table that we had before. And we can give you the AMA document as a separate handout if you find that this is hard to read. So you'll see that we have, again, the number of problems, the data, and then the risk. Remember that one of our CPT codes has been eliminated, the 99201, the low level new patient visit is no longer a valid CPT code. So we don't have any information assigned to that. So if we go on to the next slide, let me just bring to your attention a little bit. There are a couple subtle differences in the 3 categories. So previously, we looked at the number of diagnosis or management options. Now it's the number and the complexity of the problems that you address at the encounter. We had amount and the complexity of data to be reviewed. complexive data to be reviewed, but now it says analyze. So now there's more credit for looking at laboratory results or looking at records from another entity like an urgent care center or maybe another physician. The risk of complications or morbidity or mortality is still there, but now it defines that as risk of complication and or morbidity or mortality of patient management. So the changes are subtle, but they're a little more specific. So if we go on to the next slide, you'll see that this helps you choose your level of service. And again, remember, if you're doing it on medical decision making, you're going to do 2 out of the 3 elements. You'll see that we have 4 levels for most all visits. Our 99211 visit is still a valid CPT code. It's that very minor visit that you may or may not be doing health wise. It doesn't necessarily have to be done by a clinician. It can be done by your staff, although the clinician should be in the office suite at the time that they are doing that. Some health plans are not covering this particular CPT code as being done as telehealth. So what I want to do in the next few slides as we move on is I want to delve into the specific elements of medical decision making a little bit. So we have 4 levels for each of our 3 elements. They're the same 4 levels that we've always had. From the perspective of number and complexity of problems that you're going to address at this encounter, it would be straightforward, low, moderate, or high. And the descriptions that I've given you on the slide here are straight from the AMA as they describe the patients that you might be seeing. But to dig into it a little bit further on the next slide, they do give you some examples, and these are all in the guidelines from CM, from the AMA. So what I would point out to you on this slide is now you'll see that there's a straight crosswalk within the levels for new patients and established patients. So a straightforward level of medical decision making is the same for a new patient as it would be for an established patient at the level 2. So it would be one self-limited or minor problem. Level 3, as we move up to a low level of medical decision making, it requires that there are 2 or more self-limited or minor problems, or one stable chronic illness, or one acute uncomplicated illness or injury. Any one of those things would qualify as low. Moving up to moderate, you'll see that the chronic illness needs to be with exacerbation, progression, or some kind of a side effect from the treatment, or you could do 2 or more stable chronic illnesses, which would move you up to a moderate level, or again, an acute illness with systemic symptoms, or an acute complicated injury. So any one of those things would qualify as moderate. Moving up to high, which is needed for our level 5 services, you need to have 1 or more chronic illnesses with exacerbation or an acute or chronic illness or injury that poses a threat to the patient's life or bodily function. So you can see that there's a lot more or in these. We don't necessarily count the number of problems that you have in any one level and allow you to move up to the next level. And I think that'll become apparent as we move on to some of the others. So if we go on to the next slide, we'll start to address the amount and complexity of data to be reviewed. This is a more dramatic change for us, and this is where it's important that you do a good job of documenting records that you're reviewing or test results that you're looking at. And we have some new terms to keep in mind here. So our amount and complexity of data to be reviewed is divided into 3 categories. It's tests, documents, orders, and independent historians. That's all one category. Independent interpretations not reported separately. Not reported separately means something that you didn't do in your practice and bill for. And it's also discussion of management or test interpretations with someone outside of your practice, an external physician or other qualified or appropriate source. We'll delve into that a little bit more, the three levels, as we go on to the next few slides. So the next one shows this is what you would need to do at the limited level. So each unique test or order that contributes to a combination of two or more, or a combination of three within the categories below. So we have two categories in the limited level, category 1 and category 2. To meet what you need to do for category 1, which are tests and documents, you need to do any two out of those. So if you ordered each unique test and you ordered two tests, then you would have met category 1. If you ordered one test and you reviewed the results of a different test, a test that you didn't do in your office, that would be one, and you would meet your combination of two there. So you do count the numbers here. You can do combinations of anything as long as it's within the same category. On the next slide, that helps us move up to the moderate level, and you see now we have three categories here. Category 1 is, which still is your test documents, and your independent historian has moved up to category 1 here, where on the previous slide, in the low level, your independent historian is a category itself. So now we've moved that independent historian up to category 2. Category 1. Our category 2 is still independent interpretation of tests. And then we've added a third category of discussion of management or test interpretation. Again, it's with somebody outside of your practice. As we move on to the next slide, which gives us the elements for high, we have the same three categories with the same three things in each category. However, the difference between moderate and high is for moderate, you need to do one out of the three categories. For high, you need to do two out of the three categories. Same elements. All right, then moving on to the next slide. I just want to define a couple of terms for you. In that whole element of data to be reviewed, we have the phrase not separately reported. Not separately reported means that
Regina, if you give me 1 second.
In your practice and bill for it. It's something that someone else outside of the practice did. So for instance, if you're billing for a rapid test, strep test that you did in your office, that wouldn't count as part of your medical decision making because you separately billed that, and along with that comes the interpretation. Another phrase that we want to talk about, which is on the next slide, is independent. We have independent historians and we have independent interpretations that we talk about with this. So if we can go on to slide 21 or 22. There we go. So if a physician interpreted the test and is billing for the interpretation, we don't count that in determining our level of medical decision making. If the physician is reviewing something from outside, like an image, and you did not bill for it separately, then that is considered part of the data that you review towards your medical decision making. So the bottom line is you don't count time or work twice for anything. So if you're doing for it and billing for it separately, you get paid for doing that, but we don't count that towards determining what our level of medical decision making is. And so the same thing with independent on the next slide. We have independent historians. For you in pediatrics, you very often will have an independent historian because a parent is considered an independent historian. Someone that needs to be there with you and is conveying information of some kind to you. Independent interpretation is someone outside of your practice that has done a test or a study of some kind, but you are reviewing the results. And that does count towards determining what your medical decision-making level would be. So that's data and complexity of the data and reports and everything. The third element of medical decision making on the next slide is risk. We once again have straight, low, moderate, and high levels for that. And while the AMA and the CPP panel tells us that these are common terms to all of you clinicians, and you will determine what that level of risk is, and you don't require, it doesn't require quantification or for these definitions in your documentation themselves. But as you'll see as we go on to the next slide, and the table of the four different levels, the top two levels, moderate and high, do have some examples of what is considered to be moderate. So minimal is just, minimal risk. Again, remember this is to any additional diagnostic testing or treatment because it's towards the management of the patient, not necessarily what the diagnosis is. Low is the same thing. When we get up to moderate, we still have prescription drug management as moderate, decision to require minor surgery, or a decision required to do some kind of elective surgery would be considered at the moderate level itself. The AMA has said when we determine minor surgery versus major surgery, we're not going to use those typical postoperative days that are assigned to those different surgical procedures. You, the clinician, will determine whether it's a minor surgery or a major surgery. If we get up to the high level for our level 5 services, we do have fairly significant high risk here. The AMA has this year with these new guidelines further defined what drug therapy requiring intensive monitoring for toxicity means. That was always kind of a gray area, and with not a lot of a clear explanation what that meant. They've also defined a few other things that would be considered that. So then, as we go on to our next slide, this was the same slide that I showed you earlier. So now we've got our three elements of medical decision making. You need to do 2 out of the 3 to determine what your overall level of medical decision making was. If you do all 3, you're going to take the 2 highest out of the 3 if they're not all at the same level. And there will be some times when you don't do one of these elements. There may not have been any type of data to be reviewed or analyzed, for instance. So you would pick your level based upon the problems and the risk. So that's medical decision making, and that's one of the options that you have for picking your level of service. I want to briefly talk about time a little bit before we finish up here. The major thing for you to remember now is that time doesn't have to be spent on counseling and coordination of care. Now you're going to include all the time that you spent on this patient encounter for this particular day. A couple of specifics to remember is you're still going to be doing other E&M services in your practice. So different categories of services now have used time differently. So it's important to review the instructions of each of the categories because all of the other codes other than these 99202 to 215, they still have the same time requirements that they have always changed. The time requirements were no longer having to do the bulk of the time on counseling and coordination of care is just for the 202, the 205. And lastly, the third and probably most important thing to remember is it's your time, the clinician time, the practitioner time, not the staff time. We can't take what the staff is doing into this. But as you'll see as we go on to the next few slides.
Mary Jane, I just want to remind you we have 4 minutes left.
Okay, we're going to wrap up very shortly. So here are the time thresholds. They no longer have specific times themselves. It's a threshold. So before you can move up to the higher level, let's say for a 203 to a 204, you have to be at 45 minutes. Otherwise, if you're anywhere like at 43 minutes, then you're at 203. So they're time thresholds instead of specific times. And we can move on to the next slide, which is pretty self-explanatory. But these reviewing either test results or maybe old records before you start to see the patient. That counts towards your time. The time that it takes for you to do the history and the exam, that obviously takes time too. I will point out that you'll see documented clinical information into the electronic or other health record counts towards your time too. But remember, it has to be on the day of the encounter. If you go home at night, finish after your day, and early in the morning you log on and you finish up your documentation from the day before, that time doesn't count. The time where you do all of these activities has to be physically on the day of the encounter, which is what I'm pointing out to you on the next slide about time itself. It has to be done on the calendar day of the encounter, and it has to be the clinician time. The next, so we often get the question about, well, so what exactly do I have to document as far as the time? Do I have to document that I spent 3 minutes doing this, and I spent 4 minutes doing that, and I spent 7 minutes doing this? No, you're going to document the total time that you spent, and then just summarize what activities you did during that time. I'll caution you that it's probably not a good idea to use your electronic health record in and out time, because that doesn't adequately describe or account for anything that you did before you logged into the patient. Okay, so just the total time, and then tell us what it is that you did for the patient during that time. Before we finish up, I want to just remind you that there is a new prolonged service code, which we have on the next slide for you. It is a 99417. It is in 15-minute increments, not like the other prolonged service codes that are the first hour and then each 30 minutes thereafter. This new code 99417 can only be used with the 99205 or the 99215. Because remember, if you're basing it on time and you use a little more time, you're just going to go up to the next level of service for your new or established patient. But when you get at that level 5 area where you're really spending additional time, then you're going to use the 99417. For our older patients, CMS didn't agree with AMA on how you calculate the time, so they have a code they use for them. But for the most part, our commercial plans will all be using the 99417. Lastly, before we finish up these last 2 slides, so this slide gives you actually some time ranges when you would use the 99417 more than once or twice. And you can use it every 15 minutes as long as you are spending the time on the encounter for the patient that day. Okay. The next slide, which is basically our final slide, just a couple tips I want to leave with you about billing your services. Remember, right now, for most telemedicine, telehealth visits, we are not using place of service 02, which says telehealth. Most of our health plans have told us they want you to use the place of service wherever you would have typically done the service. So if it's in the office, you're going to use 11 instead of 02. Some of our health plans are also requiring that you put the 25 modifier. Most all of the commercial payers are, and in fact, asking you to put the 95, which tells us that you're using asynchronous services with that. So a couple of tips towards, submitting the claims themselves and getting paid the first time around. So with that, hopefully we haven't gone over too much time. I do have a couple of poll questions, but we can skip those if we need to get on to the case study.
Sorry, I was on mute. Thank you so much, Mary Jean. We can probably get back to those poll questions if we have the time during the conversation.
Sure.
Do we have, I'm going to stop sharing the screen. Do we have any questions right now for Mary Jean based on her presentation?
There's a lot to digest on this particular topic. This is Tim Watson, by the way.
Sure.
There's a lot of stuff to digest. There are 2 things I did not think were clear, at least to me. the very last thing you said about the 95 modifier for asynchronous treatment, I think I need to better understand that, but that could actually play into our case study. So you may want to address that after. The second question has to do with your mention of same day documentation. I think I was a little unclear on this. Are you saying that if you do a telemedicine visit, it has to be done, written, and closed the day you did it? Or are you saying that the time you spent the day you did it is the only time that you can bill for, even if you sign it the next day?
The time you spent doing it on that day is the only time that you can bill for it. So if you sign off on it the next day, then you can't count the 2 or 3 minutes or 5 minutes at the 50 to sign off on the next day.
Got it. Understood.
Yeah. Good question, and a common question that we often have with that. And I realize that that's a lot to absorb. That's why I gave you my contact information on the very last slide, and you're welcome to email me questions or give me a call as we go. And I think you'll find that the more you use these new guidelines, then you'll get, used to knowing them, that the child came in, they have an upper respiratory infection. I prescribed a medication for them. That's a 99214 visit.
Mary Jean, can we share the slides with the participants?
Oh, certainly, yes.
Okay, so all of you will receive the slides, and the last slide has the contact information. So we're going to proceed to the next item on the agenda, which is the presentation of a case. So I'm going to put this up on the screen. I want to remind you that we are receiving cases for interesting cases, and the link to the Google form is actually in the email communication that we sent you. So look for that. If you have an interesting case that you would like to share for the next sessions, it can be relevant to the topics or not necessarily, as long as it's an interesting case. And with you, Dr. Tim Watson.
Hi, everyone. I'm Tim Watson from Mission Pediatrics, and I was asked to come up with a issue that may roll into billing problems potentially, but issue that we ran into with our telemedicine usage. I picked a case that was not entirely unique, but I think is a common experience, at least from my colleagues. And so in this particular one, we had a 4-year-old patient who is part of a capitated HMO Medicaid plan, who the mom called to state that the child had a runny nose without a fever for, I believe it was 1 day. It could have been 2. And we have a protocol in our office that we instituted when COVID hit, that anyone who had illness, symptoms, or signs needs to get looked at and potentially triaged first with a telemedicine visit before a decision is made before they come into the office. We felt this was a safety issue for our team. For a safety issue regarding our patients. And this particular mom was not having it. She was very upset that she couldn't just walk into the office. And the staff was great in terms of convincing her that this was our first step, but it was very clear. And when I got the call, the information was queued up to me and contacted her. She was very hot and upset that she had to do this over the phone at all. Now, this to me is strange because I hate going to the doctor, and I don't know why anyone wouldn't want to just take a phone call first. But essentially, it then became a litany of problems. Her phone didn't connect. She didn't answer the phone. The staff had her on the phone for me. It transferred over, the call dropped, and that's when this whole problem began in trying to reach her. Finally, when we got her, and I was able to talk to her on the phone, and this is after multiple attempts in between patients. So it took half a day in order to just have this simple triage discussion. I communicated to mom that without a fever, without a cough, with just a simple runny nose and no other symptoms, and a child who's eating well and sleeping well, that these were things that sounded like the beginning of an upper respiratory infection, and they sounded like something that could be managed just with supportive care at home. We went through what respiratory distress looks like. We have videos that train about what respiratory distress looks like, and we referred mom to those videos to review so that she could compare what her child was doing. Anyway, so when all of those things were done and the call seemed to be finished, the call occurred the next day for the mom to essentially say she wanted her kid seen again. And it was as if nothing that was communicated actually sort of registered with this mom. Again, very apprehensive and upset, but again, not meeting any of the criteria to physically come into the office to be evaluated. Again, no fever. It was another situation with multiple dropped calls and lost calls and difficulty reaching mom in half a day. At this point, after talking with the mom, my decision was that the time involved in talking to mom, the frustration that mom had, seemed as if the bottom line was that it would be better to just bring them into the office to get seen. Because at this point, it was just a tremendous amount of wasted time for somebody who just really wanted to be physically seen in the office. So my telemedicine question is, well, first, there are some parents who don't have internet access. They don't have a phone that connects well. And it could very well be that was one of the things that was going on with her, and she wasn't able or willing to communicate that. But some people just really want that hands-on touch, and they want to come in, and telemedicine is not an option that they want to select or use. This kid did end up coming into the office, and they did end up getting evaluated, and they did have nothing appreciable wrong with them. And mom was reassured, and that was the secret sauce that she needed when it was all said and done. But when it comes to billing, my questions related to all of these multiple phone conversations, the multiple drop calls, the partial discussions, it was really unclear how to bill that. I mean, they're all documented separately. Each time something took place is documented, but in the end, the total collective time on the phone could have been easily 45 minutes over the course of 2 days or 3 days. And my understanding was that you can sort of itemize the amount of time that you spent and add that up over a 7-day period and utilize that in billing, but I wasn't certain about that. And so I think what we ended up doing is just billing once for this whole encounter. And that was it. So that's the scenario that I ran into. I are wondering if that's something that any of the rest of you have experienced. Silence. Did we lose Tomas?
No, I am right here.
Oh, you're here. Okay, you just disappeared. Oh, there you are.
So,
Rajashekar.
any comments? Yeah, yes, Dr.
Hi, Tim.
Hi.
Good presentation. This is a one-off thing, right? It's not a frequent occurrence, correct?
It's a frequent occurrence. We have a tremendous number of patients who do not want to engage in telemedicine, and they want to come in for the littlest, simplest thing. It was interesting. I was convinced that what COVID did is it eliminated the unnecessary office visit because nobody wanted to come in. I figured it would create a situation where people were less and less likely to come in for nothing kinds of reasons. But there are still a few diehards who really want to come in for seemingly nothing. And, they have a lot of apprehension and worry. They think that if someone has COVID, their kid's going to catch it and die from it. So there's some teaching that certainly can be done on that subject. But this is actually really common. So lots of drop calls, lots of upset people who don't want to go through the triage first.
I do experience some of the things that you mentioned. That is, the mother will call and say, my child has got some skin condition, for example. Okay, can I see the child? Then her answer will be, oh, I'm not with the child now. Then I'm in the shopping place or whatever. I'll be home after an hour. Okay, call us after an hour. So like that, for one condition, for one visit for a child, sometimes we may have to make 2-3 connections finally before we can see the patient. That is, but still, I bill only for one visit. But your experience multiple times with one patient, I did not have that many experiences, but calling the mother 2 times or 3 times, maximum 3 times before I can see the patient did happen to me on different occasions, but I just billed for one time.
But the thing is, can you bill for more, or can you total the time that you spent with all of this talking to the patient? I think you can. I think you could total it up over a 7-day period.
I don't know. I don't have an answer for that. Maybe Jean may have
Maybe
an answer.
Mary Jean?
You want me to jump in here?
Yes, please.
So so first of all, are you billing an office visit code or are you billing a telephone visit?
I think that right now our insurance, our health plans allow the office visit, which I think is what our billing company ends up doing. But we could go either way. I guess in the end, which one is a better pay kind of scenario?
So right now during COVID, some of the health plans have relaxed their requirements as to what is considered telemedicine. And some of them are allowing what we call audio only to be done as telemedicine. You have to be a little careful because some of the commercial health plans cut that off after the very first PHE came to an end. Now that's been extended several times, but not all of the health plans have extended that over the time. So there's that kind of that mixed bag I was talking about early on in my slides about you really have to know your commercial health plan and what it does. Some of our other plans have said that you still need to, if it's a telephone call, it's a telephone call, and you need to bill a telephone visit. What they have done though is they're now paying for telephone visits at the same rate that they would pay for an office visit. So that becomes a payment issue, not necessarily a coding issue at that point. You would still code that using the 99, I think it's 441 to 443. And then they would equate the 1 to a level 2, the 3, the 2, the 1 to a level 2, the 2 to a level 3, and the 3 to a level 4 office visit code that you did. Now your issue about would I add it up and do it over several days, or would I add it up and do it over one day? If you're doing the time, I would add it up and do it one day, even if you do 2 or 3 days in a row. You want to do it on a daily basis to add up the time. And they are per day codes, so to speak. So you could have 3 calls on one day and then add it up to be the 45 minutes or whatever. The thing that you have to be a little bit careful of with those, by CPT definition, those telephone calls, there are some restrictions there about, it can't be about something you've just seen the child for the day before. It can't lead to an office visit within the next 7 days or so. Again, right now during the pandemic, during the public health emergency, a lot of those restrictions have been relaxed by your payer. But I would think the best scenario for you to do is just add it up on a daily basis.
Okay. Thank you.
Did Dr. Emoto have any experience regarding this kind of billing issues? Dr. Emoto is on the line, right?
Yes, I am on the line.
Do you have any experience with this?
Not in terms of coding more than once. I mean, we'll sometimes have a patient who we talk to on the phone and decide needs to come in. And I just kind of call it all one visit.
And in that case, you would do your office visit, because remember, with the office visit, it's the total time that you spend with that patient that day. So you would just add your time that you spent on the phone to whatever your in-person visit was.
Okay.
Hi,
Dr. Murthy or Dr. Kalimlim, any comments?
This is Akhil Sharma. Can I make a comment?
Sure.
Okay. So yeah, I agree with Dr. Watson is saying. It is very frustrating to have these multiple visits. The only thing I can say is, as Mary Jane said, the requirements have been relaxed until this COVID situation goes. Trust me, I have no interest in continuing these phone calls. They're extremely frustrating. It is so much easier to see a patient within 2 minutes, 3 minutes in office and get all the information than have a shaking camera and mother with no patient going around a mall saying to call me back. I have no interest in that. So
Yeah.
I truly feel this is as effective as until this COVID situation lasts. If the restrictions are put back again, it is not in any of our pediatricians' interest to put the time and effort. We'd rather see patients in person. It is so much easier. But until then, yes, I do whatever is possible. My office calls first and tries to get the pearls, the ASQ screens on phone. They try to get the approximate height and weight on phone if they can. And then I call them, I give them a time that, okay, I'll call back like an hour or two later, whenever it's free, if I can get through the patient. If I don't see a patient in person, I write down video visit, but patient was not present. And then I just leave it up to, if they want to pay, they pay. Otherwise, I think it's just too much effort put in
Yeah.
for small returns.
This is Dr. Kalimnim. I'm sharing the same agreement with Dr. Sharma that if I do telehealth, I'll do one telehealth for a patient. And the next time around they call, we better see them in the clinic and see them physically rather than doing telehealth over and over again. It's easier that way too.
This is Dr. Murthy. This question is for Mary Jean. You know, like for the virtual visits via video, we are billing like 99213 or 214 with 95 modified. Is that the correct one?
That's
With
correct.
video?
With the 95 modifier, and then your 2-digit place of service should be 11.
11, okay. And if it is a telephone call, we just use the 441 or 442?
Correct. Yes.
Okay, thank you.
Mary Jean, there's a question for you in the chat box. Typically, when you bill for a consult, you're billing for a consult of a physician who works outside of your practice. What if within your practice, you have a subspecialist who you can consult with? Can you count that as a consult even though it's within your practice?
If it is a recognized subspecialist, yes. If you're in a group practice, everybody is considered part of your group unless the subspecialty is a recognized subspecialty.
Or probably a different tax ID number.
Well, otherwise, you could, if it's a different subspecialty, you can still have the same tax ID number. Otherwise, it has to be independent, has to be a different tax ID number.
All right, everybody, we are on the hour. Does anybody have any pending questions that we need to ask Mary Jean or Dr. Watson at this point before we end?
Okay.
All right.
Remember, you can call me, or, I mean, if you think the questions would be helpful for everybody, you could I'm not giving you more work, Tomas, but you could read the questions.
For those that need to leave, thank you so much for participating. You will be receiving an email from us. I will have maybe 2 more minutes because Mary Jean has a couple of questions that she wants to put up on the screen. So I'm going to show question number 1. Thank you to everyone who has to leave, but we have this question on the screen if you would like to participate. So it says, how would you credit this data? A 3-year-old patient and her dad come into the office and follow up to an urgent care visit over the weekend. The pediatrician notes that she read the PA's note and reviewed the lab results from the urgent care visit. Obtains a history from the dad. Now, is this credited as a limited, moderate, extensive, or don't know? If you can play some answers. Anybody else? 4 more seconds. And these are the responses that we have so far.
So I would agree with all of those of you who said moderate. This would be considered moderate data because you need to do one of the three categories. Category one is, of course, the test documents or independent historian, and you have 3 are required for moderate, and you have review of an external note, review of the results of a unique test, and an independent historian, the lab. So
Okay.
you could couple this with whatever your risk was, or whatever your the number of problems, and you'd have a level 4 visit.
Now, the second one is if you're using time to select a code, what should you document? Time range, the actual time, the time to the nearest 15 minutes, or the EHR in and out time. Right? That's what we have.
Okay, so you're going to want to document the actual time. Don't document the range, and I wouldn't. And you can no longer use the 50% rule or the nearest 15 minutes. You need to document the actual time, and then just summarize what it is that you did using up that time. And don't
And
forget
last
to,
question,
okay.
if I order a bill for a quick strep test in my office, what do I count? Is it the order, the review, both order and review, or neither? And our replies.
Okay, so we have some confusion here. You would count neither one of those towards your medical decision making because you ordered it and you billed for it separately. So it doesn't count as part of your medical decision making here. Remember, the data that you're reviewing has to be from an outside source, something that's not separately reported. Separately reported means there's a CPT code and I billed for that CPT code.
All right. And that is it for our program. Thank you everyone for participating today.
Thank you for having me.
Thank you, Mary Jean. And we will be sharing all the materials with all the participants. And please look at your calendar for February 18th. Thank you so much.